Okay, Hans Boers from Hanover first described the elephant trunk technique in 1983, and I think that's a stroke of genius, really, to call it the elephant trunk rather than the Boers technique, because it really did catch the imagination of the surgical fraternity at the time. Essentially, what he described was in two patients with extensive ascending arch and thoracoabdominal aneurysms, during the first stage of the operation in repairing the arch in the ascending aorta, he left a 10 centimeter graft floating in the proximal descending thoracic aorta. This facilitates the second stage operation in terms of accessing the proximal descending thoracic aorta control and anastomosis. But undoubtedly, both of these operations are decent sized operations, both the stage 1 and stage 2, and comes with this significant mortality and morbidity. Furthermore, in the interval period between the two stages, some patients would succumb to the underlying pathology, such that the number of patients actually coming through to a completion stage 2 procedure following a stage 1 is actually relatively small. So in the 10 years or so since Boers first described the technique, the retrograde endovascular stenting of the aorta was being developed. But stenting the proximal descending thoracic aorta, indeed the aortic arch, has always had its problems and is regarded as a hostile territory for the endovascular surgeons, namely because of the lack of landing zones and also the fact that the bend and the angle of the arch makes it very difficult. So it was thought that if for the small number of patients that have disease limited to their arch and to the proximal descending thoracic aorta, if we could prefabricate a device, join the stent to the conventional graft, and stent the proximal descending aorta antegradally during the first stage repair, then we would in fact turn a 2-stage operation to a 1-stage operation. And Havridge described 4 cases actually in 2003, 3 aneurysms and 1 chronic dissection. And he carried the metaphor of, that Boers usually called it the frozen elephant trunk. This isn't the Havridge device, it's actually the Tech device, the Thoraflex hybrid. But I'm using it really to illustrate the point. You can see that the stent's been deployed and sits fixed in the proximal descending thoracic aorta, therefore it's frozen bit. And the conventional graft is used to repair the arch. Here they've used the distal anastomosis just distal to the left subclavian artery. In fact, you can simplify the procedure quite considerably by moving that anastomosis to either zone 2, zone 1, or zone 0. And I think that it really, really does simplify the procedure when we do that. So since the first devices were talked about, several of them have come onto the market. I think the Havridge device is really historical now. The Hanover group has moved over to the Avita Open when it became commercially available in 2009. Since 2012, the Thoraflex hybrid from Tech has come onto the market. In the Far East, the scene is slightly different, but the principle is the same. The Cronus graft in China, it comes in 2 parts. They're still antegradally stenting the proximal descending thoracic aorta, but the stent actually comes with a sewing cuff, whereby during the operation you actually anastomose a conventional plexus graft to repair the arch. The Japanese have also got their own model. Here it does come prefabricated together, the stent and the graft, but they've pre-curved it to accommodate for the bend of the arch. None of these devices have FDA approval, so they're not available in America, but I think they're available on a sort of research basis. In Europe, we're really talking about the Avita Open and the Thoraflex hybrid graft. In the Far East, you're talking about the Cronus graft, and there the coronary stent, and there you're talking as part of the Sun technique. There's been over 20,000 implants in China of that stent, so we're way behind. In Europe, there's been up to date, there's been about 6,000 implants for the Vita Open and over 2,000 implants for the Thoraflex Hybrid. The data, the device data, very similar for the devices. They come in different sizes. The smaller sizes that are available in the Far East probably reflects on the patients. I think the big difference is in the delivery system. I think the Thoraflex Hybrid system is slightly easier to use, but also the integrated branch that you get with the Thoraflex Hybrid, for me, makes arch repair a lot easier. There is some suggestion that the radial forces of the stent of the Thoraflex Hybrid graft is slightly less compared to the eVita Open, and it may be more useful in acute dissections. This is the outcome data of the devices that are available. You can see the Chinese are operating on patients that are way younger than most patients in the Western world. There is a suggestion that the Vita Open may have a higher mortality, but I think it's quite clear that the cohorts of patients are slightly different. But undoubtedly, these are big operations. There's significant mortality associated with them, and also there's significant morbidity, in particular stroke and spinal cord injury. But what's been happening to these devices since it was first described in 2002? This is the review of the practice in Hanover, and there's no doubt that over a 12-year period, proportionately there are more frozen elephant trunk techniques performed now in their unit compared to the conventional elephant trunk technique. And I think that's true just talking informally with aortic surgeons, and certainly reflects our practice in Southampton. Why is that? Well, the reason is because we've moved away now from the original indication, that's patients with isolated or disease isolated to the aortic arch and proximal descending aorta. We're now using it in patients with extensive disease involving the arch and focal abdominal aneurysm, a bit like a conventional elephant trunk. You can treat it, you can leave the stent floating in the proximal descending aorta, and you can treat it a bit like a conventional graft. You can clamp them, you can sew onto them. And my endovascular colleagues say that it's easier to stent into a stent rather into a free floating graft. I think it's a very neat way of repairing arch saccular aneurysms. You can keep your dissection away from the aneurysm, you can keep the dissection away from the recurrent laryngeal nerve, and you can use the stent and the graft to exclude the aneurysm. Acute pyridate dissections, if the tear is in the arch and you're committed to doing some procedure in the arch, I think that the FET device is very useful. What it does is that it re-expands the true lumen. It actually either depressurizes the false lumen or completely obliterates it. And if you do your anastomosis in zone 1 or zone 2, you would think that the amount of bleeding is much more because the operation is much more extensive, but that's not been our case. And I think that's in the case of our experience, and I think that's to do with the fact that the false lumen is either obliterated or depressurized. And there may be a case actually in doing that, even if the tear is not in the arch, if there are patients that are young with DeBakey type 1 dissections, because there is some suggestion that there will be positive remodeling of the downstream aorta, therefore preventing or reducing the need for secondary procedures. Chronic dissections, I personally have some issues about using the stent, the device in chronic dissections, but I'll just go into that a little bit more later. These are from our own series in Southampton. This This is the first case we did about 3 years ago now. It's the ideal case, really. Patient with isolated disease or limited disease in the distal arch and proximal descending thoracic aorta. There's a slight variation. I don't know whether you can pick out on the third. I don't have a pointer, but there's on the third CT slide, the left vertebral artery actually comes off the aortic arch. There's a slight variation which you have to be aware of, particularly if you're using the branch technique to reconstruct the arch. The fourth CT was performed about 2.5 years later, and you can see the graft's well deployed, it's well seated, the aneurysm has been excluded, and there's been positive remodeling of the proximal descending thoracic aorta. And the last slide just shows the left vertebral artery having been anastomosed to the left common carotid as part of the original repair. Patient's doing very well. This is a patient with a more extensive aneurysm. You can see we've used the FET device. It's well seated, but it's incompletely treating the rest of the thoracic aorta. What we did was that we brought him back about 4 weeks following his first procedure and performed a retrograde endovascular stenting of the thoracic aorta. And you can see in the last slide there, the aneurysm has been excluded, treated, and it's thrombosed, and hopefully over time there will be positive remodeling of the descending thoracic aorta. This is an arch aneurysm, sacral aneurysm. It's our most recent case, actually, did about 3 weeks ago. This patient had a normal voice, and there's the intraoperative photograph with the head and neck vessels isolated. Well, I was able to keep the dissection well away from the aneurysm and away from the recurrent laryngeal nerve. And there you can see the device in situ, the stent has been deployed. The fact that you can see the distal anastomosis shows you that I've done it quite proximally. That was a zone 1 anastomosis, and the branches align nicely. And you can see the subsequent CTs a week later of the arch aneurysm being excluded and thrombosed. This is a DeBakey type 1 dissection that we had recently, fairly typical with the tears in the proximal mid-arch. We used a FET device to reconstruct the arch and stent the aneurysm or the dissection. And you can see the true lumen is fully expanded, and there's been obliteration and exclusion of the false lumen. So I think it's a device that has good potential in acute dissections. In chronic dissections, we haven't operated on this case yet. I brought it up just to illustrate a point. A patient who's had previous dissection repair with a composite root, but now he's got residual chronic type B dissection, dilated. And those of us who operate on these patients know that the true lumen is usually very small. The membrane is usually thick and non-compliant. We measured it here around about 1.2 centimeters. And we know that these devices, when they're collapsed and mounted on the delivery system, they're about 1 centimeter in diameter. So my concern is that if you put this device into the true lumen and deploy it, I think there's a real risk of either under-deployment or undeployment of the device. And I think we all know the sort of complex relationship in terms of perfusion of downstream organs. So malperfusion on these patients do actually worry me quite a lot. But you can't argue with these pictures though. It's quite compelling evidence. It comes from Essen. It actually comes from Jacob's paper. And you can see they've deployed the stent in the true lumen, and it's sitting quite nicely. I'm not quite sure whether I accept the fact that the true lumen diameter is increased. I think what they've done is changed what's a crescent-shaped structure to the circular structure. But there's no doubt that the false lumen has thrombosed, and the false lumen has decreased, and there's been positive remodeling of the aorta, without jeopardizing any perfusion further downstream. So there are cases where I think it's reasonable to use the frozen elephant trunk technique in chronic dissections. But I think you have to be selective. This is data taken from the FET Open registry in the device being used in chronic dissections over a 5-year period in 5 centres, probably the major aortic centres in Europe. They've managed to come up with 90 patients. That's less than 5 patients per year per unit. So there's great selection going on. And despite that, the mortality is still quite high. Complications still high, particularly spinal cord injury and stroke. All the patients with gastrointestinal complications died, and there's even a significant number who went on to have permanent dialysis. I think a lot of these patients have had a malperfusion problem when the stent's been deployed. But there's no doubt the FET device in chronic dissection is used. In the UK, about just less than 20% of patients have the device for chronic dissection. As a single entity, aneurysm is still more common, but in combination, either acute or chronic dissection is probably the most common in terms of the device being used. This is not surprising. The device being used in patients as they get older for aneurysms increasing. Chronic dissection gets less as the patients get older because they're probably been treated earlier. A steady number with slight increase of acute dissections as patients get older. Now this is the stent size of the stent graft and disease of the UK population. You can see it's a bimodal distribution. And in other words, we're using the smaller stent sizes in the patients who have dissection, who are younger. And the aneurysm patients have the bigger size stent. The pattern is similar in terms of the worldwide experience, but slightly skewed towards the smaller size. It may be that we are not as aggressive as the rest of the world in terms of treating acute and chronic dissection with this device. I think time will tell. This is the result from Southampton. We've only done 22 cases, so a smallish number, so I think it's pointless to apply statistics to these. We haven't done any yet in chronic dissection, so the data comes from acute dissection and aneurysms. Just under 50% of our patients are acute dissection. We've got slightly more females than males, which is slightly different from other published theories. But otherwise, the patient characteristics are fairly similar and not too unusual. These are big operations. How I tend to do them is I use right subclavian artery cannulation. I go down to 20 degrees. I use unilateral SACP unless there's a drop in the left-sided oxygen saturation, whereby I will put a separate cannula up the left common carotid. I tend to put a stent, do the distal anastomosis, do the left subclavian common carotid, and then the innominate artery in that order. But there are you can shortcut some of those times. You can reduce the length of cooling and rewarming by doing that different stages. But that's the order I tend to do my operation. And so far our results have been quite pleasing. We haven't lost anybody yet. And furthermore, we haven't had any major complications such as stroke or spinal cord injury. We did have one patient with a brachial plexus injury, but that was temporary, and he's fully recovered now. And we haven't had anybody who's had to go on permanent dialysis. So far, we've been pretty pleased with the results. Again, follow-up is pretty short-term. Being followed only 14 months. We've only been using this device for about 3.5 years. But we haven't lost anybody during the follow-up period either. How do we compare with the other people, bigger centres? This is the Essen data from Jacob. Significant morbidity and mortality. A slight difference in the acute the dissection and aneurysm patients, but significant morbidity and mortality. This is the data from Hanover. Similar, there's some suggestion that the mortality may be slightly less compared to the Essen group, but not too different. And I suspect different patients are not directly comparable, but again, significant mortality and morbidity associated with the procedure. So how's this device been taken up in the UK? There's been over 200 implants in the UK now. This is just Thoraflex hybrid data. Most of the implants have gone in 4 centres, Papworth, Liverpool, Birmingham, and us. I think Papworth leads the group with over 50 implants, if I'm not wrong. There are other sort of moderate centres with in Hull, Coventry, and Bath. Overall exposure to this device in this country has been about 67, two-thirds of the units in this country have had experience with this device. How does it compare with the Evita Open? Don't forget the Evita Open has been on the market now, or in the present in the UK for 5 years longer than the Thoraflex hybrid. So far there's only been 59 implants of the Evita Open. Now that may mean that as a group of surgeons in the UK we prefer the Thoraflex hybrid. I personally think it's a better device in the sense that the delivery system is simpler. I think the integrated branches makes arch repair easier, and I think the radial force of the stents makes me more confident in using it in acute dissection. Of course, it may be a marketing effect because the Evita Open has over 6,000 implants worldwide. In Europe or in the world, don't forget that the US hasn't come into play yet. It's not available. When they do, I suspect there'll be a massive skewing of data towards the US. And in the Far East, we've got 25,000 implants of the Cronus stent and the J-Garf as well. But in Europe, most of the implants of the Thoraflex device is in Western Europe. And within that, it's mainly in Germany where there seems to be little resistance in taking on new devices and new techniques. For us, we're very similar to the French and the Italians. We account for about 10% of the market, 30% decomplying or fielders. So in conclusion, I think the frozen elephant trunk technique devices are coming of age, and I think it's a great addition to the armamentarium of aortic surgeons. I think it lies somewhere in between a conventional elephant trunk and the endovascular techniques, either with debranching or without debranching. I think it certainly simplifies surgery for patients with multi-segment aortic disease, particularly when you're able to bring that distal anastomosis forward towards you. I think it prepares for second stage operations when necessary in a nice way. As I said, I think the endovascular, the interventionalists prefer to stent into a stent to the endovascular secondary plan. And I think, as shown, we've moved away from the original indications. The indications have increased. I think in this country, particularly in specialized aortic centers, its use is going to increase because I think the use in acute dissection is going to increase. I think the number of chronic dissections will also increase. And I think there may even be indications of using it in, for instance, DeBakey type 3, high-risk DeBakey type 3 type dissections. So I think that's where we are at the moment. I'll be happy to take any questions. If you haven't got any questions, this is a quiz.